My name is Carrie Ann. I'm the general nurse educator facilitating general orientation. I'm the one, me and Yan are the one sending you emails and replying to your emails. And thank you for joining us this afternoon. We're going to start the afternoon with a land acknowledgement. We would like to acknowledge that we are gathered here today on the unceded and traditional territories of the Musqueam, Squamish, and Tsleil-Waututh people. Just a reminder that we'll be conducting the afternoon session in Zoom, so please keep yourself muted and be on time. We have breaks in between. Come prepared for questions, be respectful, and please put your full name on the participant section, just because that's how we take attendance. So we need your first and last name. And Jan here is taking attendance to make sure that you're registered on our session, and that's how you get compensated for the time in attending the general orientation. This afternoon, just like this morning with new employee orientation, we will be using Slido. This is how we're going to facilitate interaction with our presenters. This is where we can ask questions and answer questions. So if you go to slido.com, #GoPHC, that's the event code. And that's how we get to interact with each other. We will try that on. So I'm going to let you guys go to slido.com and put on GoPHC, #GoPHC. And the first Slido question is, Jan's going to put it up, the Slido question. So what are you most excited about working for PHC? What are you most excited to be part of PHC? New learning experiences, the community, thank you. New work environment, meeting new people, teamwork, community. I heard the PhD team is excellent to work with. Thank you. You have an experience on that one. New population, new community, and new work environment. Joining the community, embracing the friendly culture of PHC, benefits and teamwork. I'm already a PHC employee and I'm happy to continue working for such a wonderful company. Thank you. Meet new people, community. Okay. Thank you. Thank you for the reply. I'm going to carry on with the presentation. So this is Burrard Building. So St. Paul's Hospital, Burrard Building, more than 125 years ago. And you still see this as the facade of the Burrard Building. So here, I'm just going to put this on. Laser pointer. Okay. So this is Burrard Street in itself, and that's our Burrard entrance. So there's that in St. Paul's. We have two main buildings. So Burrard Building, which is this one, and most of the inpatient care area is in the Providence Building. So when you come in at some point this week, either for orientation or to start your work, you will be coming into the Burrard Building. So Burrard entrance, going in there, and when you get into Burrard entrance here, just follow the blue line on the floor. There's a blue line on the floor. It gets you to a set of the elevators. And if you're coming in here for safe patient handling, like for tomorrow, from this set of elevators, go straight to the 9th floor. Or if you're coming in for orientation for tomorrow as well, some of them is on the level 1, so 1 floor down. But this is the set of elevators that you're going to take to get you to where you need to be. Okay, so from the Burrard entrance, follow the blue line on the floor and get you to that set of elevators for your in-person session. This is the new St. Paul's, and we are currently building it, and I guess everybody knows about it. This is the new design, and it's in the terminal station, so Main Street and Terminal Station. This is how it's envisioned to be. Employee absence reporting line, we call it EARL. Please take note of this number. You can do a screenshot and put this number on your phone. So it is an automated system that records absences when staff are sick or unable to attend work. So when you call EARL, it would ask you for your employee ID. So make sure you input your employee ID, and then it will prompt you to press 1 and 2. Eventually, it will lead you to leave a message to your manager when you call EARL. And please don't call when you're not feeling well. Don't call straight to your unit. Call EARL, because if you don't call EARL, it will be marked as no-show, and we don't want the no-show. We want proper recording of things. So call EARL. Have this number on your phone handy. I have it on my phone because if I need to call in, it's there ready to go. Parking in downtown Vancouver. So St. Paul's Hospital requires staff hangar to be eligible for staff parking rate, and there's also a pay by code. So we staff members for St. Paul's, for Providence in itself, St. Paul's, Mount St. Joe, Holy Family, or the long-term care site, we need the hangar, a daily hangar here. You can get the hangar from the Connect, the website, the intranet that we have. Apply for the hangar, and I believe it's $20 for the hangar. Put in the car, and when they see the hangar, they know it's staff. So St. Paul's have a dedicated staff parking, limited though, but there is staff parking for St. Paul's. And for MSJ, if you have the hangar, you have free parking within MSJ site. MSJ also have a lot of free street parking there. So daily pay is $5.50. Some people have it bi-weekly payroll deduction, but the main thing is you need to have a staffed parking hangar to get the perks of the parking downtown or parking in MSJ. Connect, this is what we call our intranet, and it houses all the resources that you need. This is where you can connect from to get to your pay stub, to check your email would be here. Policies and procedures are here. Job postings are here. What's happening at St. Paul's or Providence Healthcare in itself would be in Connect. So basically, for you to be able to access Connect from home, you need to first activate your network access in a PHC site. So the first logged in should be in a PHC site. So when you come into your workplace the first day, when you open your internet, when you log into your Infosys, check your email, then when you activate when that's been activated, then you can check Connect from home. So that's easily accessible. Another website that you need to know is ANGO. So it's an online scheduling procedure, and it's where pretty much we shop for a shift. So it's PHC online scheduling system for unionized staff to view their schedule, update their contact preferences. It's also where you can bid on available shifts in the near future or weeks in advance. You can customize how you want to be informed for your shift. You can have text messages sent to you, email, or they can call them. You can get a call to. So ango.phcnet.ca, that's where you can get more how to bid some shift and how to get some shifts. And you can go to ango.providencehealth.org for more information, or you can just go to Connect from there. Professional image. So we at Providence Healthcare, we believe that professional image is important, and this includes by wearing our photo ID. So we all wear our photo ID when we walked around the organization. Also having a name tag. So I have sent you an email. Included in your welcome email is a link to apply for a name tag, because it takes a good 4 weeks for that name tag. So you can put your birth name on the name tag and your pronouns on the name tag as well. We encourage people to use hello, my name is. So pretty much introducing yourself to the patient, to your family, and tell them your name, tell them your profession, and tell them what you're about to do. For example, hello, my name is Carrie Ann. I'm a nurse educator, and I'm here facilitating and coordinating your general orientation. So that's how we encourage our healthcare professionals to reach to speak to talk to our patients and their families as well. Fit testing. Fit testing is done annually, so any staff member carrying or coming into close contact with a patient with whom there might be a known or suspected airborne illnesses requires the use of an N95 respirator, and this must be fit tested annually. So for you to learn more about when the fit testing is available, it's walk in right now. Go to Learning Hub 12787. So most high risk area have a fit tester on the unit. But if you have been fit tested in the last year, that you still have a valid fit testing ID, please send that ID or certificate from another health authority to OHS at providencehealth.bc.ca, and they will tell you if that's valid, or they will tell you if you need another fit testing done. But any questions in regards to fit testing, email OHS at providencehealth.bc.ca. Violence and prevention. So this is part of the orientation modules you received from HR, from the new employee orientation learning hub. So the modules are all mandatory before beginning work, and high-risk areas require classroom training. So please email violence and prevention when you have completed your Learning Hub modules on violence and prevention. Please send that certificate, Learning Hub certificate, to your manager and to violence and prevention at phsa.ca. So this email here to get paid. So send the completion certificate and to violence and prevention and to your manager so you can get 4 hours of pay. BC Emergency Color Code. So this is pretty much the provincial color coding. And to activate a code, please dial 7111. On our acute site, there is a button to press for code blue. On our emergency site, there's also, aside from the button to press code blue, they also have a code white button. I just would like to add that as of last week, we also added another code, which is what we call code silver, active attacker. And so we will be adding more information on the BC emergency code, color code. So there will be a silver code and it's active attacker. So just for you guys to know that there is another code there. And to activate the code silver, it's also dialing 7111. So this week's schedule, if you're unsure about your schedule, please feel free to email gophc at providencehealth.bc.ca. And if you attended the session this morning from new employee orientation, Jan will be putting it on the chat, the email for you guys to, if you have any questions with regard to pay for NEO, that's the email to go to. So NEO stands for New Employee Orientation. Jan will put it in so you have it on your resources. Thank you. Okay. So we're continuing our session this afternoon with this is a recorded presentation from our Indigenous Wellness and Reconciliation team. The person who's going to speak to us today is Olivia Palomino, and she has a very good presentation. It's recorded, and if you have any questions, we'll connect by the end of the presentation.
part of the Indigenous Wellness and Reconciliation team here at Providence Health. Thank you. Hello, everyone. My name is Olivia Palomino. I'm the coordinator for Indigenous Cultural Safety as part of the Indigenous Wellness and Reconciliation team here at Providence Health. Thank you so much for joining me on our presentation on Indigenous Cultural Safety, our Indigenous Wellness and Reconciliation team, just an overview of what we do and who we are. So first of all, I'd really like to start off with a land acknowledgement, which is where I always start my presentation. So I just wanted to say that, we are all here on Musqueam, Squamish and Tsleil-Waututh land, and that we are respectfully acknowledging that, we all live, we create memories on the unceded homelands of the Musqueam, the Squamish and Tsleil-Waututh. We hold up our hands to our friend relatives who are on the land as land and water stewards of this territory. We thank them for peacefully hosting us on their sovereign lands while we continue to find ways to create harmony and peace on the path towards truth and reconciliation. Just a quick note about land and land acknowledgements. For non-Indigenous Canadians or settlers, land acknowledgements are an opportunity to reflect on the impacts of colonialism, to be accountable to Indigenous people and thank those who still live on and care for the lands. These few words spoken at gatherings can provoke thought and reflection about colonialism and how to engage in reconciliation more meaningfully. Land acknowledgements aren't just scripted words. They are not just words that we recite, but one common convention is to use the words traditional, ancestral, or unceded territory. These are words that you will hear often when referring to the land. And we say traditional to recognize how land was traditionally used or occupied by First Nations groups. We use the word ancestral to recognize that land is handed down from generation to generation. And we use unceded to recognize that land, that land has not been turned over to the Crown through treaty or any other agreement. So it is still unceded territory. So just a little heads up as to why we use a little bit of that language, because it is something that you will hear often. So again, thank you so much for joining us today. So I just wanted to thank you and welcome every single one of you to the general orientation with PHC today. Today we're here to take a moment to discuss Indigenous wellness, reconciliation, and PHC's commitments to these. The Indigenous Wellness and Reconciliation Department, IWR, as I'll refer to it, was formally established in June 2020. We continue to grow and create space for new programs and opportunities for learning within PHC. When we speak about reconciliation in relation to the work that we do at PHC, we're asking everyone who's not Indigenous to be in a place of self-reflection, to make a personal commitment to the practices of humility, to take up the responsibility of learning, and to teach yourselves about the past, the present, and ongoing history of colonialism and the impacts experienced every day by Indigenous people. This is the spirit of true reconciliation, and this is the hope that we have for each of you as you start your journeys here at PHC in whatever capacity that you may be working with patients. We recognize that there's going to be Indigenous patients across the board throughout every unit department, whether they are patients, residents, or here for any day treatment. I also need to just throw out a trigger warning. So some of the topics that will be discussed moving forward through this hour together may indeed trigger some anger, disbelief, sadness, and this is all okay. Those are your feelings to process and to explore further. And I ask that you take care of your own needs as you are presented with this information. So the Indigenous Wellness and Reconciliation Department is a growing team. Currently, our team members and our leadership include Harmony Johnson, who is our Vice President. We have Neil Fowler, who's the Indigenous Wellness and Reconciliation Manager. Theo Jacob, who's the Executive Assistant. We have Sherry Hunseth, who's the Director of Indigenous Relations and Community Engagement. Clint Barton, who's the Coordinator of Indigenous Relations and Community Engagement, as well as our Indigenous Wellness Liaison Team. So our liaison team is made up of Angela Thompson, Olivia Scout, Jay Curry, Rebecca Watt, and Paulette Neese. We have an Indigenous peer support. Right now it's Sage, and there is space for one more peer support who will be hired. And so that is our working team at the moment, including myself as the Indigenous Cultural Safety Coordinator. So we are a growing team. We continue to expand. We are forever expanding into our tiny space, but we're very excited to be here and to start to engage with all the units. And as new employees, I think it's really critical for you to know who we are and know that we are here to support patients in every capacity that we possibly can. So our Indigenous Wellness Liaison, they're an internal specialized consultation team within Providence Healthcare. They are, as you saw in the last slide, for the majority of our liaisons do hold bachelor's degrees in social work. However, they are not working in social work roles within their capacity. So they are a specialized consultation team that works very closely with the social work department, with the nursing department. They are able to ebb and flow out of any unit, and they're connected very much with cultural supports. They are trained social workers working in specialized roles. So the IWLs, these are our liaisons, support self-identified Indigenous patients and families by facilitating access to cultural practices, traditional medicines, ceremony, and access to the all nation sacred space, in addition to connections to community supports, including elders. So they do a lot of work across the board supporting Indigenous patients, so they have a more holistic, culturally safe experience while they're here at the hospital. And it's important for you to know that because you have the capacity to reach out and connect with them. So IWL services can be offered to all patients, and it's up to each patient to self-identify as Indigenous and consent to the services. And that's just how our process works. We really do want to ensure that all patients are at least asked if they're Indigenous. If they self-identify, then we can start to provide those services and connect them to the proper supports that they might need. So we have to always remember that consent is critical to the safety. And although the Indigenous Wellness Liaisons work with Indigenous patients, not all Indigenous patients or Indigenous people will want to engage with our services. And this is absolutely okay. We pass information on to them and we let them self-refer as well. The peer support program provides some lived or living experience to patients and families receiving services and provide emotional support to help facilitate culturally safe, appropriate care. So as of September 2017, Providence Healthcare signed the Declaration of Commitment to Culturally Safe, Cultural Safety and Humility within health services for First Nations and Aboriginal people in Canada and in BC specifically. This vision for cultural safety and humility will really be achieved by creating a climate of change. And this is what we're working on here at PHC with our programs, with the expansion of our team, is to really engage and enable change. So implementing and sustaining changes and then reporting and having a progress, ability to report progress. As employees at Providence Healthcare, you're all part of this declaration of commitment. And aside from just the declaration of commitment, we also want to ensure that we're all aware of what the Truth and Reconciliation Commission of Canada has put forward as the calls to action. So this is a good opportunity for you to use that humility and that curiosity to get to know what these reports are about. So Reclaiming Power in Place is the Missing Murdered Indigenous Women's report on missing murdered Indigenous women and girls. We've got the declaration, so UNDRIP, it's what it's known for, which is the United Nations Declaration of the Rights of Indigenous People. And all of these have helped to form our Declaration of Commitment. So the importance of understanding these declarations includes having knowledge around these other portions and very important reports that have come out. So I want to talk a little bit about the spaces that we hold here. So we have the All Nation Sacred Space, which is located on Burrard Level 4. I'm not sure if any of you have seen it yet, but you most likely will know about it and hopefully will have the opportunity to go in and check out the space itself. It is a all nations sacred space, and there is no designated space really for ceremonies outside of this area. So we use this space for as many group ceremonies, family ceremonies, individual patient ceremonies. So we have a lot of use for this area, and we really want to have people use it, come see it, check it out, see where it is, so that you are able to support any patient who might need and want to utilize it. Um, if there is no designated space for ceremony, or if it's an undesirable opportunity to transport a patient or resident, then there are very specific steps that are taken in order to continuously give cultural support to these patients. So we want to ensure that all patients at least have access to some sort of ceremony or culturally safe practice. So we do also make ceremony available at bedside. We do this by creating a safe place and a safe plan with our team and plant services risk management to determine the suitability of a secondary location. So if a patient is unable to make it to the sacred space, then we will go to the patient at bedside and support them if possible, if it's safe, and if it's something that we can potentially do for them, then we'll do our best to do that. All PHC programs and departments are to work with our department to facilitate Indigenous patients in having timely access to ceremonial use of traditional medicines and ceremony. When the Indigenous Wellness Liaison team is supporting a family or patient with ceremony, you as a staff member will know it's taking place. So it's not done in secret. Everyone will be aware. There's a process to it. A sign is placed on the patient's door. Smoke detectors are temporarily deactivated for the duration of the ceremony, and then they're turned back on. And this is why we work so closely with plant services and risk management, because we do that coordination. So our liaisons will do that piece, that portion of coordinating and ensuring that things are safely done. It's incredibly meaningful for Indigenous patients to access this ceremony while they're in the hospital. And we as a team must continue to work to ensure Indigenous patients are connecting to appropriate cultural supports while they're patients or residents at Providence Health. So this is one of our commitments that we continue to take very seriously. So at PHC, we have a policy around the use of traditional ceremonies. Smudge and smudging. So Indigenous ceremonies involving any burning of substances are known as pipe ceremonies or smudging cleansing ceremonies, and they're used to heal the body, mind, and spirit. We also have access to cedar here on these territories, and so cedar branches are used as a brushing over a patient's body in order to sweep away energy, negative thoughts, and to bring calm, clearness of the mind of the patient. So you may see some of these ceremonies taking place. You may see an elder walking around with cedar branches, and it's just for you guys to know and to be curious about. Most Indigenous people across Turtle Island use a variety of medicine plants, and the most commonly used of the sacred medicines are sage, cedar, tobacco, and sweetgrass. Now, this is not to say that other things cannot be used. It changes from territory to territory. It changes from culture group to culture group. So it is important to just be mindful that you may have a patient who asks for a very specific medicine. If you don't know what it is, give us a call, connect with us, get curious about it so that we can support that patient. So I just want to take a moment to talk about the TRC, which is the Truth and Reconciliation Commission. And we did mention it a little bit further back as one of the kind of cornerstones of declarations of commitments and why we've come forward. So the TRC is a component of the Indian Residential School Settlement Agreement. It's a mandate, and its mandate is to inform all Canadians about what happened in Indian residential schools. The commission will document the truth of survivors, families, communities, and anyone personally impacted by that experience of going to residential school. So this includes First Nations, Inuit, and Métis former residential school students, families, communities, churches, former school employees, governments, and other Canadians. So everyone was really part of creating that document. And why do we need to re-educate? So Indian residential schools are a part of our shared history. a history that is not well understood by many. Canada's relationship with Indigenous people has really suffered as a result of the Indian residential school system. Healing and repairing this relationship will require education, awareness, increased understanding of the legacy of the impacts that are still being felt for everyone that's involved or everyone who has a relation involved. So when we talk about reconciliation, what is reconciliation? There's an emerging and compelling desire to put the events of the past behind us so that we can work towards a stronger, healthier future. The truth telling and reconciliation process is part of an overall holistic and comprehensive response to the Indian residential school legacy. It's a sincere indication and acknowledgement of the injustices and harms experienced by Indigenous people and the need for continued healing. This is the profound commitment to establishing new relationships embedded in mutual recognition and respect that will forge a brighter future. And this is our hope, is that we are going to become more open, more aware, and acknowledge what it is that we actually need to be doing. So this next map shows British Columbia as delineed by the different Indigenous groups that exist and have existed on this territory since time immemorial. BC is currently made up of what we know as 198 distinct Indigenous First Nations groups, each with their own unique traditions and history. In British Columbia, there are 316 reserves, and there's more than 30 different First Nations languages, as well as close to 60 dialects that are spoken across the province. So this is just to give you a really clear understanding of how diverse our province is, how diverse the groups of Indigenous individuals, patients, residents that might come through PHC are, and to give you a really kind of clear map of how large our province is and how many different people do come for services through PHC. And again, some people may or may not want to identify as Indigenous. Some people may or may not look Indigenous. And so it's really important to keep those questions coming from a good place and give everyone an opportunity to make up their own minds around where they stand in relation to what they need and what they request. So again, it's an enormous territory. British Columbia is an enormous area. And so everything from ceremony, protocol, the way elders are, who and how elders are supporting patients is going to look different. And we really try to encourage individual patients to let us know what they need from us versus us telling them what we can or cannot offer right away. So we try to work in that middle space where we are really just acknowledging that they know their care, they know their need, they know what that looks like for them. And so we are here to support them in any way that we possibly can. So we're going to talk a little bit about the legacy of colonialism and the legacy of eradication. We're really taught that assimilation was the sole purpose of colonization. And we're here today to discuss erasure. So erasure of a culture, tradition, erasure of language, ceremony, and really the erasure of a people, which was that was the what was supposed to be the end result of colonizing, taking land, and enforcing that Eurocentric kind of will over Indigenous people here historically. And some of the tools of colonization included biological tools, political tools. So when I talk about biological tools, I'm talking about the impact that something like smallpox had on Indigenous populations, tuberculosis, influenza, measles, scarlet fever, these type of biological tools that impacted and helped to colonize the people that were first here. So this decimation in the population was due to novelty. Early medical researchers used this as a baseline fact that Indigenous people are more susceptible to disease, when in fact we were being faced with a very novel disease, something that had never come through our bloodlines until this time, and therefore we had very little capacity to keep ourselves safe from it. when I talk about political tools, I'm talking about the Indian Act, which denied women status as Indians, and status was patrilineal, so it came from the husband's side. I'm talking about tools such as the introduction of the residential school system, renamed individuals, so giving Indigenous individuals and children European names, and slowly changing the way that people knew and understood people, places, and things. So the creation of reserve systems, mostly on poor land with minimal or no resources at all, restricted First Nations people from leaving the reserves without approval from Indian agents, which really started a negative association, a negative relationship with the RCMP systems in Canada, which started very, very early on. Restricted First Nations people from leaving the reserves, right? So we're talking about practicing traditional spirituality. So the banning of being able to focus in or practice any traditional ceremonies at all. There was a forbidden there were rules in place that forbade First Nations from speaking their languages and appearing in public in any traditional regalia, and the prevention of voting until the early 1960s. So we're talking about 1969 if you were in Quebec, where Indigenous folks were given the right to vote. So this isn't old. These are very, very recent passings that had a deep impact. And so this is our basis for understanding how Indigenous folks engage and interact with our systems, and where that lack of trust and that heightened awareness of what could go wrong comes from, is from understanding, these were not safe places, and these systems were not built to support or help. They were really built in order to continue that decimation and continue that eradication of people. So just to continue on, and just for your information, about this continued eradication, and these are all things that I think each of you could do a lot more in-depth research on. I just wanted to give you kind of a general outline of what we're talking about when we're talking about colonization. But each of these topics really merits a good deep dive. There's amazing resources available for you to dive in a bit deeper and to see some movies about this, some podcasts about this. There's a whole bunch of information out there, but there's things such as the 60s Scoop, which really talks about, and what we're talking about when we say 60s Scoop is a time between the mid 1960s to the early 1980s, when over 20,000 Indigenous children were placed in care. The slightest concern over often resulted in apprehension of Indigenous children. These children were often sent to very far away communities, so taken right out of their own home communities, and sometimes placed in other countries. So children were taken away from their families, taken away from their communities, and then placed for adoption. And this included taking kids out of reserves and out of communities in Canada, and then shipping them off to as far away as Europe and Australia. So siblings were often separated, and children sometimes did not know what happened to their parents. They were simply scooped right off the street. Parents didn't know very often what happened to their children either. And oftentimes they were told that the other had died. And so this was really a very terrifying experience for any community to face. So now the epilogue to the 60s Scoop is what we're in right now, current day, something known as the Millennial Scoop. So currently more Indigenous children are in the care system than there were in residential schools at the height of the residential school era. And the numbers are pretty staggering. Indigenous children under 14 make up about 52% of all children in foster care. There are about 4,300 First Nations children under the age of 4 in foster care across the country. Indigenous children make up about 11% of the national under 15 population. In places like Manitoba, 90% of the children in foster care are Indigenous. And in British Columbia, it's about 65%. So it's still an incredibly high number. Our current government has declared this a humanitarian crisis, and it's very much still underway. It still continues to this day. So here we have a very clear example of little known historical fact that I just wanted to bring up to each and every one of you here as new employees. So within the bounds of our host nation territory, we have both St. Paul's Hospital, which is where we're all coming together today, and the St. Paul's Residential Schools, which is located in North Vancouver on Squamish Nation territory. The residential school, so residential schools, and I use this group of photos because they are incredibly similar to each other. So part of Canada's policy and assimilation and destruction of First Nations languages, cultures, and ways of life, residential schools partnered with federal governments and the Roman Catholic, Anglican, Methodist, and Presbyterian churches. There are over 100 schools operating between 1874 and 1996. Attendance was mandatory under the Indian Act. Parents were forced to relinquish guardianship under threat of fines and penalties. Many Métis and Inuit children were also sent to these schools. So this was an impact felt by all communities across the country. Children were forbidden from speaking their own languages and seeing their families. This was at sole discretion of the schools, and children were systemically abused in every way that we can possibly think of. And this has come to light more recently. An average of 2 hours a day was in academics, with the majority of the school day largely being focused on religious instruction, forced manual labor, or domestic labor. So what does this mean to our patients? When we think about how the St. Paul's Hospital and the residential school physically look, when we think about what it must mean for a residential school survivor to walk through St. Paul's doors, there is an impact, there is a hostility, there is trauma being re-engaged and reignited that we have to be aware of as employees and as people who work with patients closely, that these colonial systems are very much still upright. They're still having an impact on care. People still don't want to come through the front doors. And so it is very critical for us to have an awareness of what this means, what this looks like. So now we'd go into talking about what is cultural safety. Why is it that we're teaching cultural safety and humility and this understanding towards, a change that we want to create? So the definition of Indigenous cultural safety, while it's still evolving, can be described as the act of providing safe and equitable health services to Indigenous people, where the relationship between the client and service provider is built on a foundation of trust and respect that takes into account the historical impacts. So the goal of cultural safety is for all people to feel respected and safe when they are interacting with the healthcare system. Culturally safe care systems and services are free of racism and discrimination, and people are supported to draw strengths from their own identity, culture, and community. And this is a tall ask. There's a lot that we want to ensure happens when patients and residents come through the doors. We want to ensure that they feel that we understand who they are as people, that we understand what their needs are as individuals, and how culture can be a source of support. And that is why we expect each and every one of you as new employees to really work from a place of humility, a place of curiosity, a place where you will teach yourselves as much as you possibly can before coming into work, so that we really have a clear understanding of what you can bring to the table. So cultural humility is a lifelong journey of self-reflection and learning, and it involves listening without judgment and being open to learning from and about others. It involves learning about our own cultures and our own biases. Cultural humility is a building block for cultural safety. It is an overarching principle that is threaded throughout our learning and acts as a process by which change can occur. So through making this personal commitment to cultural safety and a lifelong practice of humility, and by acknowledging oneself as a learner, being open to learning about the past, the present, and ongoing history of colonialism experienced by Indigenous people in this settler state, by being brave enough to confront challenges of our own biases, and by being actively anti-racist and changing the way we think and ultimately our behaviors. So we achieve it by working towards creating meaningful relationships built on mutual respect and trust. And this takes work, and this is lifelong. And this is something that we really want to ensure everyone understands, that this is just the tip of the iceberg. This is the beginning of all the work that needs to be done. But we're here to support, we're here to answer questions, we're here to have difficult conversations if they come up throughout your time here with PHC. So some things for you all to try is to really understand what territorial acknowledgement is about when addressing an audience. Get to know what you can learn about the territory that you're on. If you get asked to do an acknowledgement, what would you say? We want you to try to teach yourself as much as possible whenever possible. And just remember that we can't assume that all Indigenous people will have a traditional belief system. We can't assume anything about anyone that we're working with. And we have to really acknowledge that people know what they need best, and we're there to support them and walk alongside them. So some Indigenous people just don't feel safe to self-identify as Indigenous due to previous experiences, especially within the healthcare systems. So we have to be really mindful of what this means when we're working with them and in what ways we can continue to be supportive. Some Indigenous people have both English and ancestral names, and we have opportunities to determine what their preferred names may be, pronunciations. And so ask questions when you're unsure. Do not make assumptions when you're working with any patient, and specifically with Indigenous patients. Identify clients' cultural, spiritual, traditional needs, and document this. It's really critical for us to work in a good way. And whatever your role is within PHC, you have the capacity to document what work you do. So when you're working with an Indigenous person, there is an expectation that you are documenting things appropriately. And if you're unsure of how to document something, then please ask your leadership team and make sure that you use your curiosity and your humility and to learn as you go. This is a lifelong process and a lifelong practice, and our team is here to help support you as much as we are here to support our patients and the residents that may come through. So this last slide is just a thank you. So thank you for spending some time with me today and listening to everything that I have to say. For direct patient support, we want you to contact Indigenous Wellness Liaisons directly. And so this is all the information that you would need in order to contact them via phone, via email, or fax. If you have access to Cerner, I'm not sure where everyone's at yet since you're all relatively new, but there is also a consultation that can be submitted via Cerner or via fax. So this is all the information that we have for you today. Thank you so much for connecting, for listening and learning alongside us. And we look forward to any questions or any concerns that you may have to please be forwarded to our email or give us a call and we'll have a conversation with you directly. Thank you so much.
Okay, thank you. Thank you. That was a good presentation from Olivia. While we're waiting for our next presenter, I'm opening the Slido to any orientation questions, any orientation related questions. And also, well, you could ask about the Indigenous Wellness Reconciliation Program as well. I could forward your questions over to them. But if there's any orientation related questions that you want to raise up, um, we can put it on Slido, then we'll answer it as we go. Okay, okay, so I'd like to ask if we have to email both Neo and Go. Um, as long for Go, so this afternoon is Go, which stands for General Orientation. So Yan has documented your attendance for your for this afternoon. But if just like if you have any questions of if you think you were late for the session this morning, email Neo. Neo stands for New Employee Orientation. So email them to make sure that your name is on their list. Then that's because it's a webinar. So the only way we can compensate you for your time, the only way we can pay you for attending the session is for us to be able to see your name on the Zoom. And if by any chance you were late in NEO that you think that they did not see you, email them, which is NEO, New Employee Orientation, at providencehealth.bc.ca. But as for Go, for this afternoon, Yan and I are manning it, so we know who is attending and who's not. And then you will get paid on so what happens is with Go, we wait till the end of the week. So general orientation is happens the whole week. So we wait till the end of the week, then we submit the invoice, the staffing. We submit the names of the people who attended general orientation Monday next week. So that's how when we submit it, then that's how they'll code it on your timesheet for attending general orientation. But any questions with NEO, go to NEO, NEO. Any questions with occupational health with your fit testing, it would be OHS. And then any questions with violence and prevention, so it's violence prevention at phsa.ca. Okay, any more questions? Okay, if there's no questions, we're waiting for the next presenter. You can give yourself a 10-minute stretch break, and while we're waiting for the next presenter.
Yeah, thank you, Terry. I'm surprised to see your everybody's virtual and you're sitting in there in the room that no one's with you.
I'm at St. Paul's Lecture Hall, and then people are at home zooming in.
Okay. Just surprised to make sure when I first saw the no one there, I thought, oh my gosh, you're by yourself and you're presenting. Fair enough. As Carrie mentioned, I've been a patient partner for pretty much, or a patient advocate, let's say, for 20 years. But I've been a patient for almost 40 years now. Whereas my journey began when I was 5 years old, and I had to deal with cancer for a couple of years. I had radiation and chemo at that time. And back in the day, I'm sure you guys remember that in the 70s and 80s and the 90s, the treatment was much harsher than it is today. So I'm dealing with the after effects. I've had many different, well, not so many. I've had numerous surgeries, pretty much most of them at St. Paul's, and I've had a couple of strokes, and I've had ins and outs. Luckily, I've not had COVID yet, so I'll cross my fingers that I'll get that. But overall, I just figure, I have a story worth sharing, and I enjoy sharing it, but also making sure that individuals like yourselves who are going to join the workforce here, that you understand why it's important to really not be completely objective, and you have to make sure you treat all the patients as humans, and making sure that you don't let the biases and stigmas interfere about how you treat an individual patient, right? Also, you have to remember why it is you're doing what you're doing, because you obviously care. And so making sure that you remember that in the confines of all your stress related job stuff, right? So making sure you remember that. But in terms of what I would want to share, I think it's important to I guess just remember the patient, remember your experience, what your experience would be like, right? Put yourself in the patient's shoes to understand what it is they're going through, and what sort of emotions that you may be going through, and ask the patient if they're going through something similar or they need help dealing with those, right? But I don't have much more to add in terms of my story, but Karen, is there any sort of other questions or any, is everybody,
The Slido is open, so slido.com, #GoPHC, if you have any questions for Vikram. So first question, Vikram, is what have you found that has improved in the healthcare over the years that may not have been there at the beginning of your journey?
in terms of anything improved, I don't really, I hate to say it's gone the wrong way, not improved, it's gone downhill. I mean, based on when I was treated as a kid, obviously, you're everybody, all the healthcare providers and nurses and doctors really go above and beyond when you're a kid. But I think as you get older, I found that the not as the disconnect between the nurse and the patient, or the provider and the patient, has become more evident, because the nurses and the doctors have become busier and have forgotten why, in terms of how to treat patients like patients, or humans like humans, right? I think you don't you don't treat your friends and your family like you would treat the patient,
Mhm.
right? So I'd hate to say, unfortunately, there hasn't really been much improved over all these years.
There is a follow-up question.
Mhm.
So what made you feel the most supported by your healthcare team over the years?
I think in terms of support, the consistency I've had the same oncologist for 30 years now, and I'm hopefully in the next 5-10 years, there's that consistency. I've had a good medical team look after me, so that I've been very appreciative of that. But like, I'm originally from Saskatchewan, and I'm sure that if I had continued to live in Saskatchewan, I may not have the healthcare team as focused as here in BC. I think that's part of it, making sure that I have the right individuals who generally care about you. I think if you have people, like, I know that there are many different families and people that come to BC, and the problem is they have a hard time finding that consistency or someone to look after them. They don't have a family doctor to help point them in the right direction, or help send them to specialists. And so I've been very fortunate to have the care I have, but I'm really, I not cry, but just more, I get a little emotional when I find that it's not the same case for everybody else in the province, right?
Yes, I agree. There is a follow-up question here.
Mhm.
I know you've mentioned how healthcare has been improving, but what areas do you think we need to work on?
Well, I mean, like in that, the engagement, I guess just interacting with patients and making sure that they feel comfort in knowing that they're being cared for, but at the same time, I think sometimes the way the systems are, it's very very hard to convey that. I mean, especially when you have very lengthy wait times for general care and an emergency department. Right, it should not take you hours and many hours or even days to see a doctor when something is not right. I mean, generally we go to the hospital because a doctor is unavailable at that time, right? So outside of the hours of a doctor working 9 to 5, right? And that's the reason why we go to hospital. But at the same time, some things I just wish that, I wish there's a better system, a better way to for everybody to be dealt with and treated as equally as humans. And just when it comes to healthcare, I mean, healthcare is not only just the physical healthcare, but mental healthcare as well.
Yeah, I agree. It's not just the physical, but also the mental health is very important.
Yeah.
To segue to that question, so when you say positive patient experience, how does that look like?
Sorry, Gary, can you repeat again?
What makes a positive patient experience?
I guess knowing that like both parties, both the provider and the patient, feel as though that the issue that brought the patient to the provider has been somewhat resolved, or there's knowing there's a next step, so to say, like a test or something that is being done to further investigate what may be the issue, right? I mean, it's very, I don't like it. I'm sure that many people are the same way, that they don't like being completely dismissed and say, oh, it's not as serious as you may believe or think it is, right? I mean, that's not the right thing to say with someone. You only do what you can to um, solve the issue and help the person deal with it. I know a lot of friends of mine they have just been, they had to go through something as a young adult a few years ago, and any time they have a test or anything like that, they're very anxious to find out what the results are. I mean, like the doctors and the nurses have to be very subjective rather than being completely objective. I know that, like the reason for that is probably you don't want to get the doctors or the nurses too emotionally involved in everybody, but I think some of us generally as human beings where we seek that comfort, or if we don't have that family or friend social side of it, we rely on the experts to provide some of that, I guess.
Thank you, Vikram. One of the questions that came up is you started your journey with healthcare when you were 5 years old. So, are you able to provide us some notable differences with your experience as a child and as now as an adult?
Well, like I said, when I was a child, it seems to be to go to the nurses or do anything. Obviously, being in a smaller community, I was raised in Regina, so the scale of the operations was much different than, let's say, if I came to Vancouver or if I was born in BC, right? I'm sure the scale of the healthcare would have been quite different, but um, there was time to definitely like have a conversation and talk to these people as you know as a kid, and then lately it sort of seems to be that as I grow up that the healthcare seems to be more about trying to see as many people as they can in such a short period of time. They're not willing to give you all the time that you need to when it comes to your care. It's sort of about like how can we help you, and then sort of bye, next patient please. Like I think that's probably the biggest change I've seen, and also the fact that we've had a huge influx of people and not enough providers or not enough healthcare professionals to deal with this influx of the population, right? How do we deal with that, right? How do we make sure that we have enough doctors and nurses that provide? And like obviously with this pandemic, I mean, this happened because the pandemic only exploded because there were living in a time where there were certain populations that feel that they don't want to believe the science when it comes down to it, and they refuse to get vaccinated, and that's why this is causing I don't want to get too political, but I think it's causing an influx where there shouldn't be an influx in our hospitals, right? Because some doctors or some parents or some people maybe don't want to inoculate themselves or get vaccinated or whatever, right? So.
Any more questions for Vikram?
Actually, Carrie, I'll mention write something in the chat here, so everybody can see it.
Vikram, you have a question here?
Yeah, I don't know. I'm just gonna write something in the chat.
Okay.
If you can see that, Carrie, can you see what it wrote in the chat?
Yes. So it's a YouTube, and it's a wrong way to hope. Maybe Yan, maybe we could put the link there for the people to access after the session. So Vikram. Oh. So one of the questions here. Okay, so one of the questions is, did you have an experience with a nurse that was particularly positive that other nurses should aim for?
Again, the only positive, I guess, the experiences I had with nurses were more as a kid, and I was able to, like I counted on, like being a kid, I really didn't understand really the relationship a little bit more, but as with nurses, but as I grew up, I mean, I was able to, after 20 years, I was able to get in touch again or communicate with a nurse that I previously known, right? And to be able to follow up and catch up with her after 20 years, it's great to be able to, I think that's important, just to be able to have that, knowing that I was not, there's still a patient and nurse relationship, but I just be able to have that, I guess, be able to, shall we say, capture the moment or the essence of that relationship in terms of, I guess, bring back the memory, so to speak, when they had a good relationship with or a good experience with a nurse, to be able to go back to that, I think is important. But I don't aside from any having a particular experience with a nurse that was really positive and what nurses should aim for, I think it's more about, remembering, we are human, that we are much more than some what we may present, because obviously when we present ourselves in a hospital or it's not who we are, right? We're so we're brought down to like our body's weaker, our mind is weaker, everything is weaker, and then only to be able to recuperate after we've healed up enough to be able to go back and sort of say thank you, or to be able to acknowledge support. I think it's very I think we need to have, I'm not trying to say that we need to have more of that, but just more, nurses to be nurses are great at what they do. But I think that, making sure that they don't let the busyness and the stereo, all this, all the, I guess the stress around doing the job, don't let that get in the way of why you're doing what you're doing, right?
I'm just going to generalize the question a bit more. So, can you share any great experience you have with a healthcare worker that had a positive impact on your healthcare journey?
Well, again, like all the healthcare interactions I've had with healthcare workers have been positive in a sense. Like I don't think I've ever, only time I had a negative was when I went to UBC, and I was actually I never had surgery at UBC, and then because it's just in the midst of the pandemic, the pre-admission was done virtually rather than in person. I think that was a mistake because I'm a very complicated patient. I require, to make sure that like you sedate me before you breathing tube in, and my throat is not as not my throat, but my jaw is not as big as it normally would be for a person of my age. Again, to be aware of these extenuating circumstances when you deal with me shows me that you care and that you're taking the time to really understand the predicaments I may face, right? I think just by doing that, I think by going above and beyond, I think that's where any experience can be made a positive experience. I know that for any sort of healthcare experience, most of the time it can be very traumatic, right? And the problem is some people don't know how to deal with trauma and they have a tough time dealing with it. But I think letting the compassion a little bit ooze out a little bit of you, so you're not completely black and white. You're not looked at as a very disheartened person, I guess.
Thank you, Vikram. Any more questions for Vikram? I think this next question is for the new hires. After listening to Vikram's story and the question and answer that we had with Vikram, and for Vikram being vulnerable to us, telling us his experience with healthcare, the good and the bad, here is a question for us. What are some key takeaway or points from Vikram's story that you think are important to patient, families, and caregivers? So this is for our new hires. What are some key takeaways that we can have listening to Vikram's story? Patient and family-centered care. Importance of listening to the patient. Every interaction matters. Yes. Treat people as individuals. Do not make assumptions about someone's baseline based on what they present with them when they are in distress. Active listening. Patients are human first. Be compassionate. More resources or logistics so that providers are less strained.
I think I want to add one more thing. Not only be compassionate, but be empathetic. right?
Empathetic. Yeah, thank
Don't
you.
don't be sympathetic. Be empathetic, right?
Thank you. Prioritize patient concern, getting to know the patient and treating them more than their illness. Spend the extra time to make your patients feel valued. Open communication, respecting patients' decision, feelings, and needs, and try to see from a patient's perspective, putting ourselves in the shoe of the other patient. Okay, I'm waiting for the one person to finish typing. All right, thank you very much, Vikram. So the other ones are bringing their support for their emotional feelings. Human interaction is very important for their psychological wellness. Exactly. It's not just the physical health, but the mental health is important as well. I'd like to thank Vikram. Vikram, thank you for your time and thank you for sharing with us and answering our questions. And we much appreciate your partnering with orientation. Thank you.
Yeah, no problem. Enjoy.
Hi everyone, can you give us a 5 minutes? I'm giving you guys a 5 minutes break as we prepare for our next presentation. Thank you. Thank you, everybody. We're proceeding to our next presentation, which is infection prevention and control. We call IPAC, from one of our infection control practitioner, Laila. What's your last? Chiribaiba.
Leila Chinibaeva.
Chiribaiba. Sorry,
Yeah.
my apologies, Leila.
It's okay. So hello, everybody. Today we're going to cover the following subjects. It's so we'll review the routine practices, additional precautions, antimicrobial stewardship, and we'll go over COVID, and at the end we'll do some PPE demonstration. So here our IPAC team. So as you see here, we have quite a big team. So it's composed of the infectious disease physicians, infection control practitioners, which are mostly nurses and some allied health. And we have epidemiologists and virologists, which is medical microbiologist, and also microbiologist physicians. Infection control practitioners, they usually cover various units at the Providence Healthcare, both at long-term care sites and in acute care settings. So our normal hours are from 8 o'clock to 4 o'clock and Monday to Friday. And we can be reached by the dialing 69357 during this time and on the weekends. And there is always microbiologist on call, which can be also reached by switchboard if you need us. So there is also, I just want to alert everybody about IPAC resources, which are available on Connect. So you just go to the clinical services and supports, go to IPAC, and in there you can find all most recent infectious control resources and guidelines. Also you can look up some precautions that you need for certain microorganisms. It's very helpful. So I encourage everybody to look into this. So what is the mission of the infection prevention and control? It's prevention of the infectious diseases, especially those which could be acquired in a hospital care setting. So what IPAC does, so as ICPs, we do the roundings in acute care settings and in long-term care settings. We help the units to manage properly those patients which have MRSA, VRE, CPO, or C. difficile, or GI illnesses, or any influenza-like illnesses. So we contact your leadership and answer the questions which come up from the staff. We listen to your concerns. We support you on best practices on how to control infections at your workplace, provide you education on how to properly do the PPE, how to do hand hygiene. We also work on developing the policies and guidelines and procedures. We do the environmental audits and we do hand hygiene audits. Also, we help out the units with their accreditation. Also, we are involved in the new St. Paul's development. We do routine surveillance of the antibiotic-resistant organisms. We run the outbreaks if they happen in the Providence Healthcare. And if sometimes also we try to identify sources of the infection or exposures by doing the contact tracings. So first we'll go over routine practices. So routine practices, this is the minimal practices that usually done, which applies to all the patients and done all the time for the prevention of the transmission of infection in a healthcare setting. So here I would like to run a Slido. So what are the routine practices for IPAC? Anybody has any ideas about this?
You can see they're typing. Oh, just maybe that slide out. So you can see. Yeah. So you can see they're typing and their answers will all come up. This is what we see.
Mm-hmm. Thank you. Yeah, so I'm getting the answers here. PPE for blood and body fluid exposures. Yes, this is correct. Yeah. Hand washing. Yeah, I would say not just hand washing, just the hand hygiene. Yeah. Okay. Point of care risk assessment, that's great. Sanitation, that's right. Yeah. Okay, so that's very good. So we got all the answers. Okay. Okay, so here are the answers. So these are hand hygiene, PPE, environmental cleaning, screening patients and residents for the antibiotic resistant organisms, respiratory etiquette, surveillance that we do for the infections in the hospital, work safe practices, and safe practices and aseptic techniques. So yeah, we've got all the answers. Okay, so the next one. So for routine practices, I just want to stop a bit more on the hand hygiene. So you see around the hospital, there's hand sanitizers, that's ABHRs, that's are at the entrances, at the nursing stations. So, and then also there is an options for you to just do the traditional hand washing with soap and water. So which one to use? Just tell me which one is better to use and which one is better and which are cons and pros of everything. So we have another slider here. So let's do another slider. When you use ABHR, the question, and when you use the hand washing, anybody can tell me? Okay. So what is the best way to clean your hands? Mm-hmm. Okay. I see here that most of the people saying that soap and water is the best. And for the alcohol-based hand rub is only 29%. Well, let's see what's an answer. Okay. All right. So the answer is actually the ABHR is the most easiest and available type of hand hygiene. So it's actually number one in comparison to the soap and water. So the cons of it is just because it's easily available, it's easily accessible, it kills most of the microorganisms and has emollients to keep your hands always hydrated. And soap and water, it's not always available to you. It requires water source and sink. And also excessive hand washing can dry your skin, right? So, but the downside of ABHR, if you not remove soil, so if your hands are soiled, then you always have to use soap and water. And so some spores, bacterial spores, also not going to be removed by the ABHR. So you have to use soap and water for that. And for certain microorganisms such as C. difficile, this microorganism can form the spores. And let's say for the norovirus, it's advisable actually to wash your hands. But the rest of the microorganisms like MRSA, VRE, and CPO, they are easily killed by just using the hand sanitizer. So the next very important subject is of the routine practices is the patient's hand hygiene. So we're all talking about healthcare providers' hand hygiene, and we all know about 5 moments of hand hygiene, which we are not gonna stop and talk about it. You all know about it, but the patient's hand hygiene is also very important. So we all have to encourage our patients to do their hand hygiene, especially when before they're using toilet, after using bedpan or commode, before eating, before taking medications, before drinking, after interaction with other patients or visitors, and after coughing or sneezing. So we have to be very vigilant about that. So the next, we're gonna just watch a small video about how important it is to do your hand hygiene and how to prevent the infection in the hospital settings. Okay.
Warning, do not confuse any lightheartedness in the following video with a glib attitude toward the problem at hand. The makers of this video are very serious about the prevention of hospital infections. Another busy day. Traffic as usual. Now look at that. He goes right past the hand gel. Doctor!
It's late. Come on, Doc. Still no better. Well, all right.
Not even in gloves? Oh, come on. That doesn't really happen, does it? If you could see what I see, MRSA, VRE, Pseudomonas, etc., etc. Your attending isn't wearing gloves, so you're not either, right? Wait, the hand gel. Oh.
What? Okay, yes.
Are those gram negatives or gram positives? Oh,
How can I help you?
those growths spread everywhere.
Yes, I am. Okay, I'll draw that blood right now.
MRSA, VRE, whatever. Good grief. Nurse, you didn't clean your hands either? Oh, man. He just had an operation, and you've put a big IV in his neck. It goes almost all the way to his heart. Please don't. Finally, that's the part I wanted to see. Clean your hands before and after every time you contact the patient or the patient's environment. If your hands are not visibly soiled and the patient doesn't have C. diff, use alcohol-based hand gel to kill those germs. See? Doesn't slow you down. Really, you should also clean your equipment just as often. Your patients thank you.
Okay. So as you saw in the short video, how important the hand hygiene is. So here in PHC, we embrace the practice of bare below elbows. So what that means? It means that there should be nothing below the elbows, basically. So if you have the uniform which is below the elbow, so you have to put it up. So that will help you with your hand hygiene, basically. So should be no watches, bracelets, or jewelry below the elbows. Simple wedding band is okay. So nails should be short. Should be no artificial nails or nail polish. So what is wrong here? Anybody can tell me. So in which of those pictures we see the wrong things, and which one is okay? Can anybody tell me? So we can just do the slider here again. So here, what is correct way of using the gloves, and what is wrong way of using gloves? Just tell me what is correct way. Yeah, so like 100% I'm getting here that holding a bedpan, this is the right way. That's correct. So we should not wear the gloves when you're charting, when you're handling the clean supplies, or answering the phone. So the most important, just do your hand hygiene before all of these tasks usually supposed to be clean. So no need to wear the gloves for that. Gloves are used, they're basically stuff, they're task specific, and they should be donned just before the task. It should be doffed after the task is completed. So we'll go over that as well in the next slide. Okay. So here are the observations that we very often see in the units. So we see some people sanitizing their gloves, some people are using double gloves, and typing in the computer with the gloves, placing them in the pockets, or they also use their gloves while they're drinking. So this is actually inappropriate. So the gloves, they actually have very small pores, and whenever you're using them, so everything is just goes straight into your hands. So whenever you're contacting mucous membranes, or you're touching the patient, whatever is on the patient or on the surfaces can go straight to your skin. So some people just wearing gloves, and then this is just provides them false reassurance. So you should not wear the gloves outside of the patient's room or bed space unless you're transporting contaminated items. You should not wear them, as I mentioned before, when you chart, answering the phone, grabbing clean supplies. Why? As I mentioned, and it's shown here, gloves, they have a small spores, and yeah, everything just goes straight to your skin. So whenever you approach the box of gloves, don't forget to sanitize your hands. And once you're done with your task, doff the gloves and sanitize your hands again. This is correct way of donning and doffing the gloves. And remember that the gloves are not the replacement for the hand hygiene. Okay, now we're going to go over point of care risk assessment. So what is point of care risk assessment? This is basically the questions that you ask yourself before you do any task. So you have to find out what you're going to do. So there are 4 aspects to it. It's the patient that you're going to be taking care of, and there is an environment that you're going to be doing this task, and task itself, and also you have to ask questions to yourself: if you're safe, what needs to be done. So about the patient, so you have to find out what what kind of symptoms patient has. Is there any additional precautions the patient has? Is the patient immunocompromised? Can the patient follow instructions? About the task, what task are you going to be doing? For how long you're going to be doing this task? Is it safe task for you to do? Do you have everything to finish up this task? Do you have all the equipment for this? About environment, where am I going to be doing this task? Do I have enough space to do this task? And also about yourself. Do I have correct PPE for this task? Do I need help maybe from somebody? Does anybody know that I'm doing this particular task? So if I would need to ask for any help. Do I have enough skills to conduct this task? So this is all includes point of care risk assessment. So before doing any task, you have to ask all of these questions. Okay. So now we go over additional precautions. So again, additional precautions, this is the precautions that are done in addition to the routine practices and point of care risk assessment. So these are used for the patients which are suspected to have some infections or already alerted for some infections. So, so we're going to go over those that commonly used in healthcare settings. So these are additional precaution signages, which are usually posted outside of the patient rooms. Sometimes they also could be, they're normally are patient specific and addressed to the certain bed number. So the signage actually tells you what PPE you have to wear. And also as a nursing, you have to alert the housekeeping staff what precautions they have to use when they do the terminal clean of the room. We're going to go through some of them in more detail. Okay, the most commonly used precautions are contact precautions. And these are for the antibiotic resistant organisms such as MRSA, VRE, and CPO. So for them, usually surfaces can be easily cleaned with wipes, Cavi wipes or Acyl wipes. And hands can be cleaned with ABHR or soap and water. And another one is contact plus precautions. These are usually used for the GI infections, for the C. difficile infections. For them, actually, this is for the, like for C. difficile, cannot be killed by the Cavi wipes or Acyl wipes. So there's special type of cleaning used for this, usually chlorine. And the healthcare provider is expected to wash their hands after the contact with the patient because this is a spore-forming microorganism. So as it's shown here, so we use bleach cleaning for the patients which are positive for the C. difficile and norovirus. Okay, so the just Cavi wipes or ACL wipes are not helpful with these microorganisms. And usually, if your patient positive for C. difficile, or sometimes we also have patients who are termed as indeterminate for C. difficile, they're treated as positive. So IPAC will be ordering bleach cleaning for this room. Okay, now we're going to go over the term which called patient zone. The patient zone is basically, it's the immediate patient surrounding. It's within the 2 meters of the patient. That zone is called patient zone, which includes equipment around the patient, the bed rails, IV pump, whatever is inside the patient zone is within the 2 meters of the patient surroundings. And this area is very frequently touched by patient and touched by healthcare providers. Equipment gets inside and gets easily contaminated. So, and then outside of that zone is considered a safe zone. So whenever you go inside of that zone, you have to clean your hands. And when you leave this zone, you also have to clean your hands. Whenever you touch the patient or patient environment, that's very important. So whenever you bring any supplies inside the zone, they become contaminated. You should, even if you don't use them, you cannot stock them back in a clean supply area again. So they have to be discarded. So if you provided care and you've been wearing gloves inside this area, touched anything inside this area, so you have to doff your gloves when you leave, and you have to do your hand hygiene. So the next slide, let's do the next slide about this. Okay. So the question is, how long the organism can live in the patient environment? That's the next question. Let's try to answer. Okay, slide. Okay, I'm getting various responses here. Hours and months. Yeah, I'm not getting years though. Okay. Hours. Okay. Well, very good answers. So 60% of people saying that it's hours to days, and 33% answering that it's months. Okay. So the answer is, it depends on the microorganism. Okay. So you all heard about antibiotic-resistant organisms such as MRSA, VRE, CPO. So those antibiotic-resistant organisms, they can survive on the surfaces for the various times. Some of them can survive for like 20 minutes. Some of them can survive for the hours. Some of them can survive for a month. If no cleaning happens, they can survive for a prolonged period of time. For example, C. difficile spores, they can survive for months and months if the surfaces are not cleaned. CPO actually can survive for a prolonged time. That is one of the most dangerous antibiotic resistant organisms. So let's talk about CPO. So that is called, it's CPO, the abbreviation. I don't know if anybody heard about it. It's carbapenem producing organisms. They developed resistance to some of the last resort antibiotics. The most of them actually developed in third world countries where the population has unlimited access to antibiotics. So they actually can transfer this resistance genes between species, basically between gram-negative bacteria, for example, like E. coli or Pseudomonas, so even between species. So if the patient becomes colonized with it, usually it lives in GI tract, so they can easily get colonized with it. And if they become infected with it, it can be really deadly. So the 50% of patients can die if they get infection, like if they get bacteremia with it. So that's why we really worry about CPO in our healthcare facilities. But luckily, if you follow certain precautions, it can be killed with proper cleaning and proper hand hygiene. If we properly clean and disinfect equipment, if we do proper decluttering, so housekeeping can do the proper cleaning after the patient leaves. So that is very important, especially the hand hygiene. So this is the time that how much microorganisms can survive on the surfaces. So as I mentioned, so VRE can live up to the 4 years. MRSA can live up to 7 months if surfaces are not cleaned. And CPO can live up to the 30 months. And C. difficile or norovirus can live also for years on the surfaces. So routine practices again, as you see here, this is one of the rooms in St. Paul's Hospital. It looks really, really scary and unsafe for the patient and for the healthcare provider, unfortunately. So our role as the nurses is also to encourage the patients, do not clutter their spaces. This actually makes your work dangerous, and the housekeeping cannot do the cleaning properly. So yeah, so the clutter is a big problem again. So we have to ask our patients, do not clutter the spaces, and that actually helps us to do the proper cleaning and prevent the infections. So everybody is responsible for cleaning and disinfecting. So as a nursing, you have to do that. You have to clean the equipment, Dynamaps, especially all the equipment that goes inside the patient zone gets contaminated. So these are the wipes that normally used in our healthcare facilities. This is ACell wipes, Cavi wipes, Kimtech wipes, and this is the Clorox. This is the bleach cleaning that is done for the C. difficile patients. So just make sure, look at the dwell time. It's all listed at the bottles. So for the ACell wipes, it's normally 1 minute dwell time. For Cavi wipes, it's 3 minutes. For Kimtech wipes, this is used for the screens, for the your WOW screens, for the computer screens. It's also 2-step cleaning. So it's the same type of wipes also. And for Clorox, it's normally used by the housekeeping for the C. difficile patients. So environmental cleaning basically consists of 2 steps. So first step is cleaning process. First, you have to get one of the wipes, those wipes that I showed you, and do the cleaning of the area. So that is rub and scrub. So basically, you're just getting rid of the dirt, and that is just for cleaning of the dirt, the first step. And the second step is the disinfection step. And then after this disinfection step, you have to wait for certain time, there's a dwell time when disinfection happens based on the type of the cleaning wipes that you're using. Just make sure that it's done, and then the disinfection done basically during this second step. So we have to make sure it's air dry, the surfaces are air dry. Okay, now let's talk about COVID. That's SARS-CoV-2 virus that causes COVID-19 illness. So as you probably all know, it's been around almost 3 years now. Unfortunately, people, sometimes they don't know that they can transmit it, they can be sick, and they don't know that they have it, and then they can get easily transmitted to other people. In PHC, the patients which have COVID, they're placed on airborne droplet and contact precautions, because basically transmission happens by combination of airborne particles and droplet and contact ways. So just be familiar with it, because it could be different than other healthcare authorities. Patients who have COVID-19, they usually spaced in the red zone, red spaces. We have dedicated units in Providence Healthcare. It's 7B and some areas in intensive care unit. Normally, if the patient is not immunocompromised, they're placed on isolation for 10 days. For the immunocompromised patients, it's 20 days isolation. Sometimes people can shed their viruses for a longer time. So in that case, they can be longer on isolation. For the long-term care and mental health, they are normally on isolation only for 5 days. So we not always have isolation rooms for the COVID-19 patients. There are some made-up isolation room which have portable air handling units in some of the rooms. But again, that all depends on the space. We have a space problem, unfortunately. So as the healthcare provider, we encourage you to have properly fitted N95 masks when you handle the patients with COVID-19. So make sure you are fit tested. So it's supposed to be done every year. So we encourage you to wear N95 when you handle the patients with COVID-19. Okay, so why we need N95 protection? So this is actually the best type of protection for all respiratory viruses and for airborne precautions. So we don't have any shortages right now for the N95 respirators. So all the units have enough supply and have enough access. So the same mask can be worn between patients as long as they are not soiled or damp, or so you can change them if they become soiled. But if they're okay, so you can just wear them between patients. Do not wear 2 masks, because this way you can easily contaminate it, and when you have 2 masks, you're not going to get properly fitted mask on. Okay. So again, this is all about COVID. Okay, so for the COVID, droplet contact precautions, airborne precautions, or airborne and contact precautions. This is all could be for the COVID-19 patients, and also for TB. We also use airborne isolation for TB patients with tuberculosis. So this is most commonly patients that we see in the healthcare setting is COVID-19 and TB. And also remember for the influenza virus, it's droplet and contact precautions, but we also encourage you to wear an N95 mask when you're handling these patients as well, because for all respiratory virus, the best protection is N95 respirator. And whenever you have a patient with influenza and the patient needs aerosol generating procedures, also wear always N95. That's very important. Okay. Now let's talk about rapid antigen testing. So this is applicable for the PHC. So we use rapid antigen testing a lot. It's very helpful to actually to identify if the patient is having COVID-19 infection at the moment. So it will help you actually to find out what to do with the patient, whether to keep the patient in or move it. So it will give you an answer right away. So it has to be properly documented in the IU section, in a quick view, point of care testing section. So this is the way it's supposed to be documented. So we use it actually so to diagnose patient and also to de-isolate patients. So let's say the patient was on isolation for 10 days and on day 11, we ask you to take the rapid antigen test. If the test come back negative, the patient can come off precautions. So we use it also for the de-isolating the patients. And this is actually part of the legal charting. So it has to be properly done. So we usually leave a note for the nursing staff when the patient needs to be de-isolated and when the rapid antigen test need to be done. And it needs to be documented in an appropriate location. So it's very important to know how to do it. So you can ask your nurse educator in the unit if you're not sure how to do it and where to document it. So usually it's done right. It's just documented right here. So in a PHC, we have antimicrobial stewardship. What it means is that we look after excessive antibiotic use by the healthcare providers. So that helps to prevent antibiotic resistance. Inappropriate antibiotics will lead to increase of the C. difficile infection. So whenever, especially when the patient is on wide spectrum antibiotics, we'll try to ask healthcare providers to narrow it down once it's clear what type of pathogen the patient has. So there is an app that I encourage everybody to download. So it's shown on this slide. It's called Practical Resources for Antimicrobial Stewardship. Okay, so it's basically a very helpful app. It will tell you what guidelines to be used for various infections and antibiotics. It will tell you what additional precautions is needed for certain type of the microorganism. And it's quite regularly updated. So I encourage everybody to download it. Okay, and also if you're not sure about certain precautions, you always can look it up. As I already showed you where in IPAC section. And also you can look up the guidelines in SHOP for all organisms and diseases that most commonly you can find here in PHC. Okay, now I'm going to do the PPE demonstration. So whenever you access PPE, so you have PPE cards at the entrances to the patient rooms. So always do your hand hygiene step. So do not access any of the clean supplies without clean hands. Okay. So I'm doing my hand hygiene step. Okay, usually 15 to 20 seconds. Okay. So the next thing is to get your gown. So we have multi-use gowns in the units.
Lila, your camera's there.
So make sure you do it properly. We see a lot of nurses, they don't tie it at the back and they end up trying to provide care, which is not right because you're exposing yourself to the patient environment, which is full of microorganisms. So just make sure, or if there is somebody around can help you to tie it, just ask them. So it has to be done properly on both sides, in up and down, and around the waist. Okay. So the next step is to do your is to don the gloves. So I did my hand hygiene step before, so I can touch the glove boxes. So when you do that, just make sure the sleeves are covered. Okay, this is the right way. Okay. So make sure your sleeves are covered. So the gloves are the last PPE that you put on before going to the patient. Okay, so you go to the patient room, you provide your care, and while you are inside patient room and you finished with your care, you have to doff your gloves. Okay, so the right way of doffing, you have to properly dispose them. Make sure when you do it, just try to contaminate your hands as much as, like, do not contaminate your hands as much as you can. So you dispose it in the garbage. Garbage here. Okay, and after that, you have to do your hand hygiene step after you doffed your gloves. Okay, then you have to untie your gown. And when you do that, make sure you do not contaminate yourself and just wrap it. Okay, and put it inside the dirty hopper. Should be always a hopper inside the room, so you have to dispose it inside. Unfortunately, I don't have it here for demonstration, but yeah. So it's okay. Then because you know that the gown could be contaminated, right? You have to do another hand hygiene step. Okay, now I can get out of the room. Okay, this is the proper way of doing it. Okay. Okay. Okay, so any questions? How it is determined?
So they can see.
So how is it determined which patients get screened for CPO? Okay, very good question, actually. So when the patient gets admitted to the PHC, in the emergency department, they get asked those questions, like if they had healthcare outside Canada within the last year. Okay, so the patient answers this question. And there is a section in the admission form. There is an infectious diseases screening form there where you can type. So the patient if the patient answers yes, then there is another section there which tells which country he visited and if he had healthcare, which country he had it for how long. But it's a very small section, but it is enough already for that form. If the patient answers yes to this question, that already triggers the CPO screening test for the patient. So, so once the patient gets admitted to the unit, the admitting nurse will collect the swab. And IPAC, when we do our daily surveillance, we'll look into that. We'll interview the patient as well. Like, for example, if the patient had healthcare within the year, but more than a month ago, usually one CPO swab is enough. But if the patient had healthcare just recently, sometimes patient come straight from one healthcare facility outside Canada to here. In this case, we screen the patients 3 times for CPO. We screen patient at admission, then 7 days after, and 21 days after. The reason it's done 3 times in this case is because let's say the patient has got CPO just before arrival here. So it takes about 21 days for the bacteria to colonize the GI tract. And this CPO lives in the GI system. So we take the rectal swab for screening. I hope I answered your question. So the next question is, if healthcare workers smell C. diff when they go home, is there any hygiene practices recommended before and after going home? That's an interesting question. So, okay. So if, like, for example, if the healthcare worker worked with somebody with the patient who had C. diff, right? So there is a specific smell, I agree with that. So the only thing that you can do, you can just wash your hands when you come home. Just take a proper shower with soap and water, and that should be sufficient. Yeah, to get rid of the bacterial spores if you've got them on your hands. But proper hand hygiene with soap and water and just taking proper shower is enough. That's going to be my answer to you. Any other questions? Is there a part of Cerner charts where we can check to see what infection a patient has? So if you're talking right now about disease alerts, so that is in a banner bar. Like when you go to Cerner, when you go to the patient chart, you have to look at the banner bar that has disease alert for the ROs. ROs is antibiotic resistant organisms like MRSA, VRE, and CPO. That's antibiotic resistant organisms, and that one is usually in the banner bar. So you always have to look at the banner bar to know if the patient has those things. Okay, so and also you go to the microbiology section of the patient results. That will also, and then go to the results, check the results always, and then that will also can show you if the patient has other infection besides the antibiotic resistant organisms. Like patient can be admitted with TB, and then TB is not shown in the banner bar. It's not shown as the disease alert. It's just a disease that that patient has, right? So you have to always check the banner bar for the ROs and for the isolation that the patient is on. Like for the COVID, as I mentioned, it's airborne isolation, airborne and droplet and contact isolation. For influenza, you have to look up there, like it's droplet and contact isolation. For TB, it's airborne isolation. For C. difficile, it's contact plus isolation. So always pay attention to the banner bar. Okay. So next question, is it 10 days isolation for COVID starting from start of symptoms or at the positive result? That actually, it's also a very good question. So sometimes, yes, when we leave a note in the patient chart, we usually write from the time of the symptoms onset or the positive result. So sometimes we cannot say 100% when the symptoms started, so we go from the positive test date and time. So either way is okay. So that's, yeah. And this is, again, this is for the patient who is not immunocompromised. Okay, so for the immunocompromised patients, it's 20 days. And like for the normal patient who is not immunocompromised, on day 11, you can start doing RAT test. If RAT test is negative, the patient can come off precautions. And usually, IPAC leaves a note with instructions how to de-isolate patient. Okay. Any other questions? Okay, thank you very much. Oh, thank you. Okay. Thank you very much.
Thank you.
Thank you, Laila. All right, thank you. Before I proceed to the next topic, which is the interprofessional collaboration, I'd just like to answer two questions that was left. There was one question in Slido regarding orientation for tomorrow. So if you're coming in tomorrow for safe patient handling, you'll have to go upstairs to the 9th floor, and Yan and I would be there. You need to sign in to be able to get paid for the day. So sign in at the 9th floor elevator landing. Yan and I would be there tomorrow. And there's also a question regarding pay on that we won't be able to meet the cutoff, the question in the chat. general orientation has to gather all the hours before we submit it, because it's the way staffing will be able to organize and see how many hours that was that you did for general orientation, because they will be billed in one bulk. So that's why we have to wait till the orientation's finished for the week before we can submit the general orientation invoice. Because orientation itself is for the all point of care staff, not just for allied, not just for nurses. So it runs for the whole week for everybody. So we have to wait for everybody to get the hours in, then we can submit it, because that's the only way that it won't be confusing for the staffing to submit to payroll. So there are times wherein it's odd from the cutoff, from payroll cutoff. There are days where it's odd time for the cutoff. So we just have to do what would be best for everybody for when it comes to invoicing of the pay. Okay. So we're gonna go forward to our next presentation, which is interprofessional collaboration. And for this session, the objectives for this session is pretty much for us to build awareness of the various healthcare professions, scope of practice, promote communication and collaboration among healthcare professionals, and identify ways on how we can mitigate barriers to patient care. So we'll start with a registered dietitian, and she's going to tell us when will be the best time to collaborate with them.
Hi, my name is Catherine. I'm a registered dietitian working at St. Paul's Urban Health Program on 8A. And essentially what I do as a dietitian, I detect, assess, and treat, monitor for malnutrition. And dietitians do this across multiple different areas in the hospital. With every inpatient unit, there is a different dietitian, as well as in our outpatient units and in our long-term care sites as well. And we particularly are careful with this in a hospital setting, in the acute setting, because 45 to 50% of our patients are actually moderately to severely malnourished. And once we have assessed that someone is at a risk for malnutrition, we are monitoring on an ongoing basis just to make sure that their nutrition needs are actually being met. Whether that is being done through food, so orally, or we're also assessing their nutrition needs when they are on tube feeds, as well as TPN, so when they're being fed intravenously. And we'll also be involved with nutrition education. So this can be on a nutrition education for a short-term basis if they're managing symptoms of some medications that they may be on while they're in hospital, or it could be for nutrition education of chronic diseases. So we do this on an inpatient basis, but maybe not quite in as much depth as we would like. However, our outpatient dietitians can go into this with patients in much greater detail, so they can be in the diabetes treatment center with our renal dietitians, as well as our general outpatient dietitian as well. And our nutrition interventions, they are very much tailored to the specific person. So nutrition interventions can be greatly different between someone who has renal failure versus who maybe has diabetes or has just had a heart transplant, or is coming into the hospital and is sick with HIV and has food insecurity issues. So it can look very different between patients. And lastly, we also help out a lot with discharge planning. So making sure that the patient is set up for continuing to meet their needs when they're at home as well. So making sure that they have adequate food access, connecting them with community resources or with community dietitians if we think that they're going to be on an ongoing high nutrition risk once they're discharged from hospital. And we may also apply for funding for them through the ministry as well. So since there is maybe one dietitian per unit or per ward, we can have up to 50 patients on our caseload. So you imagine it's quite hard for us to actually screen every single patient as they come through, depending on the acuity of the unit. So we do actually rely quite a bit on other healthcare staff to help us out with screening for who may be at risk for malnutrition, who may benefit from seeing a dietitian. So from nurses, we do really encourage them to ask patients what we call 48-6 questions. So has the patient experienced any weight loss, unintended weight loss in the past 6 months? And have they experienced any changes to their appetite or intake within the past 7 days? So if they answer yes to any of those questions, that can be an automatic referral to the dietitian. So how you consult a dietitian is just by going into Cerner, adding an order, and you can write dietitian consult, and there it will pop up. And you can just indicate the reason, and we'll try to see them within 48 hours. And from there, we can decide whether or not we'll see them on an ongoing basis.
Message from our registered social worker. When do we collaborate with them? So if there's any disposition planning, home support or long-term care plan, long-term care transition, caregiver support, and if our patient needs to locate their next of kin, if there's any financial or housing issues, if as a health worker you suspect or patient discloses abuse or neglect, we reach out to social worker. And they help us with advanced care planning, representation agreement, power of attorney, goals of care discussion. And it's also our social worker is there to help provide emotional support for grief and loss, lifestyle changes, fears related to illness, and support at the end of life.
Hello, my name is Neve. I'm a physiotherapist working at Providence Healthcare. So one of the times you'd want to collaborate with physiotherapy is when you have any concerns about your patient's ability to transfer or mobilize safely and independently by themselves. One of the ways you can determine this is by using the quick mobility screen that you can see on the slide here. And it can be found on SHOP in the Falls Injury and Prevention Guideline. If you do this and you find that your patient can't independently complete all the steps of the quick mobility screen, that's when you would want to collaborate with the physiotherapist on your unit. And that might include elderly, your frail patient, or those who are at high risk of falls. The other group of people you would want to collaborate with physios with are those who have difficulty clearing their chest secretions. In terms of referral, there are actually some care pathways where referral to physiotherapist is automatic. So for example, at St. Paul's Hospital, anybody who's had orthopedic, cardiac or breast surgery would be referred automatically to physio. Also anyone with a new CVA, BPPV, cardiac arrest, lower extremity skin grafts or new amputations. And the other people that, or group of patients that need to be referred to physio are those who need help with discharge planning. And the sooner you refer to physio for those concerns, the better. So patients who have mobility concerns or have equipment needs that are related to that, such as a walker. So in terms of some communication tips, multiple regular activity and mobility is really beneficial for our patients. And getting patients up and moving is everyone's responsibility. So we do ask that you do screen for mobility before you refer to physio. But in saying that, if you're still not sure what to do or whether you should refer to a physio, please don't be shy in asking. We're always happy to help. Thank you.
This is Jay. He's an OT and he has a message for us.
I'm Jay. I'm an occupational therapist. Welcome to Providence Healthcare. I hope you enjoy your time with us. And it's going to be a long time. So occupational therapists work across all sites at Providence Healthcare. What we look at are functional issues related to how a person does the activities that are important to them. Most likely in acute care, it's going to be related to basic activities of daily living. So those are things like getting ready in the morning, getting to the washroom independently, being able to get dressed. Other things that we do in the hospital system here at Providence is work with patients, residents, and clients with specialized devices, such as things like adaptive cutlery if someone's having challenges with eating. Occupational therapists work at Providence Healthcare, generally speaking, from 8 to 4. We work Monday through Friday with a full slate of occupational therapists, and then we have weekend coverage with fewer folks. You should consult OT as soon as you feel like your client or your patient or the resident is going to have a problem with functioning. So if you're working in acute care, you're going to want to, if you're worried about how someone is going to manage at home, definitely refer to us early. If you're worried that somebody is going to need a piece of adaptive equipment at home, or if the family is asking you about adaptive equipment, so wheelchairs, overhead lifts, things like that, definitely refer to us. If family is asking about how the person's going to be able to prepare their meals at home, or if they're requiring a lot of assistance for shopping, getting groceries, things like that, you can put in a referral to us. We like to get our discharge plans up and running well before the person is actually ready to go home. So make sure that you put in your referral to us early. We also work really closely with other team members. So we work very closely with our physiotherapist colleagues and our speech language pathologist colleagues. We work really closely with dietitians, and definitely we work really closely with nursing staff, the doctors. We're all one big team, and we all have the same goal. And that goal is for patients to have the best care possible at Providence Healthcare. So if you ever have any questions, whether it's regarding a support surface, for somebody who has skin breakdown, if it's wondering about how a particular seating device works, don't hesitate to ask us a question. We're all wearing scrubs, so sometimes it can be hard to tell who's who, but just ask for the OT. You can also page us. Our pager numbers are pretty prominent in all the nursing stations. And while some of us might not look super friendly, we're always willing to answer a question, especially if you're new to the organization and you're trying to figure out how our systems work, because we are a bit different than other places. And if you're a new grad and you're a new to the whole working world, just tell us. Say, I'm new here. I don't really know how this works. Is this an appropriate consult to OT? So to conclude, make sure you say hello. Make sure you ask us questions if you have any. Don't be afraid to put in a consult. If your spidey senses are going off and you're worried about how how the patient is going to function at home, make sure you consult us. We're here to do great patient care and make sure people are safe when they go home.
There you go. That's a message from Jay. Next is a message from our speech language pathologist.
Speech language pathologists here cover all swallowing and all communication referrals. So I know it's other sites, sometimes occupational therapy do swallowing referrals as well, but typically here St. Paul's take all swallowing difficulties. You can refer to us at any time, and we try and come and see patients as soon as we can, but we all typically cover 4 to 6 units. So bearing in mind, we cover quite a large space, so we'll come and see your patient as soon as we can. And so obviously we assess, treat and manage patients with swallowing disorders, which is otherwise known as dysphagia. We also provide treatment and assessment for patients with communication, voice, or cognitive communication difficulties as well. So please consult us for either or both of those difficulties, and we'll really always help, including if you have a patient with long-standing communication or swallowing difficulties. We can come and see them and give you some advice if you're really struggling, or even just quite often we know a lot of the patients in the community as well. So we can good continuity of care. So when to refer to us, typically all patients have what's called a swallow screen that pops up on Cerner when they are admitted, and you can go through the questions on the swallow screen. So it just asks you to do a few confirmation questions, and then it might ask you to give them what's called a 30 ml swallow test, and you observe for any signs or symptoms of dysphagia. And if the patient passes or fails, if the patient fails, we get an automatic referral that comes through us center, and then we will get the referral and we can come and see them. If a patient passes but you're still concerned, then by all means you can send us an order through Cerner and we'll come and see them as well. And signs and symptoms of dysphagia to look out for might be coughing when eating or drinking, a wet, gurgly voice after eating or drinking, sounding like they have a lot of secretions in their throat, lots of weight loss that's unexplained, persistent right-sided pneumonia, or concerns that the medical team have regarding aspiration pneumonia. And nurses or physicians can enter an order too, so you don't have to have permission from a doctor. If you're concerned, then we would rather receive a referral and work it out with you. So yeah, for any reasons you can refer.
I can speak on some of the communication supports we also support with. And this happens with many, obviously with a patient who may have had a stroke. That's a more common type where we may see overt communication deficits in terms of aphasia, difficulty with word finding, difficulty expressing or understanding. But outside of strokes too, we also obviously work with cognitive communication, so other types of brain injury or potentially dementia, or also with cognitive decline with Parkinson's, things like that, and neurogenic disorders. We would be able to support with ensuring the patient is in fact able to share their message. And I think in the acute setting like this, we would generally work with how can they get their message known, and in terms of nursing care, and they communicate their needs in terms of needing to toilet or needing to be changed or returning to bed or getting up into a chair. So we would be able to support with that, whether it be through working with strategies and providing staff with strategies, or maybe even with communication boards so they can, again, use it, and we'll train them trial that as well. Then I'd say the other aspect we would also work on is the quality of life in terms of life as well. And that's a very big area for us. We really like to focus on this, particularly when patients, in terms of their code status, are more moved towards goals of comfort care. And that would mean that we're in our role then, working with the patient on their ability to swallow in a manner that is most enjoyable for them to enjoy their food still, in what could still be the most safe manner if able, or at least recognizing and in discussion with the patients what the risk tolerance may be in terms of accepting the risk of aspiration or dysphagia and what that might entail, while also working with them on the correct type of texture or the appropriate texture modification that they might enjoy the most, and that can allow them to have oral comfort and oral hydration, even when we're at the last part of their life, near the end.
Yeah, and then another really important thing to note is we quite often support with capacity and decision making. So if you feel like a patient has a communication deficit, but they are still able and they should be able to be involved with decision making around their goals of care, or decision making around going home, or anything like that, we can get involved and support that patient to express their wishes, and be that go-between sometimes between the medical team and the patient to support them to get their needs known.
Okay, that's from our SLP. Next is from our clinical support clerk. When we did the recording for this, they call themselves UC, but now there's a new word for that, for a new term for the team. It's called clinical support clerk. So you still hear the word UC, but it's now pertaining to clinical support clerk.
Hello, my name is Deb Shaw. I'm the UC Education Coordinator for Providence Healthcare, and I'm here to talk to you about what the unit coordinator position is at Providence Healthcare. So the unit coordinator is the person who sits at the nursing station most of the time. They are your communication guru. They're there to help you with any communication needs that you have. They're going to answer all your phone calls, do the visitor inquiries, and if you need some help in contacting somebody, a physician or something, they're the perfect person to go to. They do a lot of the person and family-centered care, including the COVID visitor screening, wayfinding assistance, and they also do the patient exit surveys. They're there to help you with any administrative support that you need, including prepping charts and documents for patients who are being discharged, following up, booking follow-up appointments, and retrieving any documents that you need from an outside source. They are there to help with the flow of the unit, so the patient's in and out. So please make sure if you're sending a patient out for a test or if you are discharging a patient to let the UC know and let them be the one who does the discharge. It makes it much easier if the UCs are aware of where people are on the unit. They, of course, can perform all those registration functions, including discharge, transfers, and admissions. One thing to note, if you have a patient who passes away on the unit, it's the UCs are the only ones who can do that process on the unit. So if there is no UC on your unit, please contact patient placement and do not discharge the patient, because there's a couple extra things that need to be done that the UCs have access to doing. If you need anything on the units, any supplies ordered, the UCs can order those for you, and they can certainly manage any maintenance needs that the unit needs. Really, they're the go-to person. They're there to support you in whatever you need. If you have any questions, the UCs are extremely knowledgeable about the workings of the hospital and how to get things done. So they're a great person to go to if you have any questions at all. One thing to remember, though, is UCs do not have the ability in the new Cerner system to actually enter in any orders. So if you need anything entered in, you will have to do that yourself.
The next person of the team is pastoral care. So this is Lawrence. So Lawrence mentions that we collaborate with them when our patient or family needs emotional support, counseling, reflection, prayers, or meditation, or when patient, residents, families need companion as they struggle to cope with changes in their healthcare trajectory. When patient requests culturally appropriate ceremonies, sacraments, and rituals, they give end-of-life support. And also patient, residents, and families need support with ethical issues or decisions. We got the pastoral care there to help us. And this is Rachel from Consultation Liaison Psychiatry.
Hello, my name is Rachel Walker, and I'm the nurse educator for the Consult Liaison Psychiatry team. We see patients throughout the hospital in all the non-mental health units like surgery, medicine, cardiac, ICU, etc. We can also see people in emergency who are admitted to a service already and awaiting a bed. Referral is physician to physician through a pager. I have my cell phone and can be reached directly for nursing issues. I technically only follow patients that have been referred to the team, but I'm happy to answer questions for anyone, so please call. The team is here 8 to 4, and after hours, you contact Psych On Call through the operator. Our contact information is on the internet. Just search Consult Liaison and it'll pop up. There's also some information about who we are and what we do. Welcome, and I look forward to working with you.
For our pharmacists, we reach out to them. Renee mentioned that we reach out to them when we suspect any drug-related side effects, how and when to draw drug labels. Also, if we have any questions with medication order management or questions about med reconciliation, they're happy to help. So anything in regards to medication, we can reach out to our pharmacists. To our respiratory therapists, this is RT. So this is Amanda during COVID, during the peak of COVID. So if our patient has an increasing oxygen requirement of more than 6 liters, we reach out to them. If a patient needs home oxygen or nocturnal CPAP, if they need bedside pulmonary function testing and proper teaching, trach care and management, transport of patients on high flow, then we reach out to them. So the request for RT is that have pertinent information ready for them when we page them, as they cover many areas around the hospital and they have to triage the call based on urgency. Here's our medical doctor. Emily Chan mentions that we collaborate with them for management of medical issues and communication of treatment risks, benefits, and disease prognosis to our patient. Family and multidisciplinary discussion regarding levels of care or social disposition. And please, said we are nice and reasonable people. Please do not hesitate to call us directly or interrupt us if there is an urgent indication. So looking at the different team in our healthcare. So what does it entails that if we practice teamwork in healthcare, these are the things that is beneficial for the patient, right? Scope of practice being used efficiently. So each one of us, we're optimizing our scope of practice. We're trying to reduce morbidity and mortality for our patients. We're promoting positive patient and family experience. And we're coordinating care between the acute and community setting. So what do you see as the barriers in promoting teamwork in healthcare? So if you look at this, these are some of the barriers that we can see. Race, culture, or sometimes it's the medication. The patient is confused. He's on medication, so we're having a hard time communicating with the patient. Speech and language ability, dysphonia, time constraints on the team, illness in itself, mental state of the patient, effects of the medication. These are common barriers. And just a reminder for each one of us that if we try to break one of these barriers, it would help our patient. So practical tips, always introduce yourself to the team and clarify your role. Learn and use people's name. Try not to call, hi RT, my patient needs 6 liters, but try to introduce yourself and try to get the name of the person on the other line. Use objective languages and avoid assumption. Be assertive when required. Read back and close the communication loop. Do a closed loop. Ask questions, check and clarify. And when in conflict, concentrate on what is right for the patient, not who is right or wrong in the situation. Helen Keller mentioned that alone we can do so little, together we can do so much. We are promoting teamwork for the benefit of our patient, and it's also for the healthcare system in itself. Thank you so much. Okay, we're powering through. Our last topic is regarding hazardous drugs. And this is a high-level discussion about hazardous drugs. But before we go into hazardous drugs, there is a Slido question here on how familiar are you when it comes to hazardous drugs? So how familiar are you with the term hazardous drugs? Okay, thank you. Somewhat familiar. Most of you are somewhat familiar, very familiar. No idea, and very familiar. Very familiar. Thank you so much. We're gonna discuss things. That's why we're all here. So hazardous drugs. Our session this afternoon is to identify hazardous drugs and find out where to find more information about them and to minimize the risk of exposure to hazardous drugs. So hazardous drug is defined as specific drugs with a potential to pose a health risk to the healthcare worker who are exposed to them in the workplace. This is due to the medication's inherent toxicity. So you can see when it comes to hazardous drugs, there is different labeling. You can see HD1, hazardous drug group 1, and HD2 is hazardous drug group 2. So the reason why we're educating new staff, but not only new staff, but everyone in the organization about hazardous drugs is because frequent exposure to low level of hazardous drugs or to a single exposure to a larger amount can put workers at risk of the negative effects of the drugs. So remember, these drugs are toxic at a very low dose. So these drugs require special handling because of their toxicity. Workers with or near hazardous medication in healthcare setting can potentially cause, these are the risks: skin rashes, infertility, miscarriage, birth defects, organ toxicity, even cancer. Remember, the risk of these drugs is due to two things. First is the degree of exposure and the toxicity of the agent. How often are you exposed to these drugs and how toxic are these drugs? Who are at risk? Pharmacy staff are at risk when they prepare the medication. Nursing staff when we're giving the medication. Direct patient staff. So basically, care aides, lab tech, building services and laundry staff, workers were involved in storage, transportation, and packing, and also the family members. So we're educating everyone because we want to create a culture of safety. What are examples of hazardous drugs? So anti-cancer medications are hazardous drugs. Anti-rejection, so patients who are on transplant or who had received heart or kidney transplant will be on an anti-rejection drug, can be hazardous drug. Antiviral drug can be hazardous drug, just like these are the names of the drugs. Could be a valganciclovir, mycophenolate, methotrexate. These could be, they are labeled as hazardous drug group 1. And then when you see a yellow label, hazardous drug group 2. So what's the difference between group 1 and group 2? So for group 1 requires precautions for handling the drug and the related waste and care for the patient during a precautionary period. So there's a precautionary period for group 1. For group 2, required handling of drugs and related waste, but there is no precautionary period for taking for patients taking hazardous drug group 2. So you just look at the label. Group 1 is red, group 2 is yellow. So when you see a red, so the precautionary period is pretty much 48 hours after the administration of a group 1 drug. So after they had a group 1 labeled hazardous drug, the patient is still on hazardous precaution 48 hours after that. That's the main difference. Okay, because during this time, the concentration of the drug or the metabolites in the person's blood and bodily fluid is considered high enough to pose a risk of exposure. So you'll see on the an infographic like this on the bedside of the patient or on the door of the patient's room. So hazardous drug precaution, and it's telling us when they started taking the drug and when it ends. So it ends 48 hours after the last dose. But just a reminder that if your patient is a transplant recipient, an organ transplant recipient that will be on an anti-rejection medication for their lifetime, there is no end date on their hazardous drug precaution. And just like the infection control infographic on what PPE you need, the picture would be there on what PPE is needed when you're handling hazardous drugs. So when do we need to put PPE on when we're dealing with hazardous drugs? So when we're receiving, transporting, and storing drugs, preparing and administering these drugs, cleaning after drug preparation, when there is a spill of a drug or a blood and bodily fluid from a patient during the precautionary period. Care of patient during precautionary period when there is a risk of blood and bodily exposure, then we need to be wearing the proper PPE. So when we're doing personal care, when we're collecting blood or other specimen, when we're doing wound care, because there is a risk. Always ask yourself, I'm not giving medication, but is there a risk of blood and bodily exposure? Then you need to be wearing your PPE for hazardous drugs. So as mentioned in the few slides earlier, this is the PPE that we need. So there is a 2 pair of gloves, chemo drug gloves. There is a chemo approved gown. So it's usually thicker than, it's disposable. It's thicker than the infection control gown. And as you can see here, the lady here is wearing a blue gown. So it's colored blue. And eye and face protection because of the risk of splash. So if you look at the photo, the mask here is a surgical mask and the other mask here is an N95. So depending on the intervention or depending on the, if there is additional precaution on your patient, you might need to wear an N95 mask. Or if there's a spill of the drug, then you need to be on N95 mask. Other than that, a surgical mask is fine. Activities that do not require precaution is pretty much if you don't have any risk of blood or bodily fluid exposure. So when you're just talking to your patient, there's a hazardous drug sign at the door, but you're going in, you don't have a risk of, you're not giving any medication, there's no risk of bodily fluid, then you don't need PPE. You don't need PPE when you go in to just talk to the patient. You don't need the PPE if you're bringing in a meal tray or you're pushing a patient on a stroller or on the stretcher or in a wheelchair, or when you're walking with a patient. You don't need a PPE for that one. Preparation and administration. So preparing and administering these hazardous drugs are 2 activities in which places an employee risks for hazardous drug exposure. So there is the ideal place. The ideal place is in the pharmacy. They have a pharmacy cabinet that they use to prepare these drugs. But what if you're in your workplace and there is no pharmacy cabinet by then? So then you go to Connect, which is our intranet, and there is step-by-step information there on how to make sure you're safe, you've decreased your exposure for these hazardous drugs. So they call that safe work procedure. These are the labels that you can see when a hazardous drug is delivered or when you're handling it. So there is this red sticker sign that says caution, hazardous drug storage and or preparation. So it could be on a door, usually door of a storage room that they have a hazardous drug door there. And these are from the medication itself when they delivered up to you. So he says here, for example, clonazepam, it says clonazepam is a hazardous drug group 2. In Cerner, you'll see these signs. Hazardous drugs would be here. It's beside the medication, the name of the medication in itself. You'll see it there, and they will flag you when you're about, like, for example, you're about to give your warfarin, you scan it, it will flag you that it's a hazardous drug group 2. As mentioned, there is a control matrix. So pretty much your resources for all of this, the hazardous drugs, is in Connect. So in Connect, occupational health website and shop will have a control matrix. So you just follow the step-by-step procedure, step-by-step information, what to do, what PPE is needed. and what type of profession or what are you're about to do. So it will tell you group 1, group 2, is it are you from pharmacy or are you nursing? What are you gonna are you giving? What are you about to do? It will tell you what you need. So hazardous drug handling. This is when, so this is what we have to put on the door of the patient, right? Put on a patient's door or a patient's bed, above a patient's bed. And then for hazardous drug group 1, so there is a hazardous waste container that's colored red. There's a hazardous drug sharps container, and this is the PPE. So you have to make sure this is what you use when you're handling blood and body fluid, because there is a risk of exposure during the 48-hour precautionary period. So you have your blue gown, double gloves, goggles, eye protection, mask, and also a sticker. So hazardous drug group 1, you have to put a sticker on the laundry bag so that our colleagues who's handling the laundry is aware that there is a risk of exposure, and also our laundry staff themselves are aware of that one too. So hazardous drug group 1, the color is red. So red sharps container, red waste bin, and then red sticker. Hazardous drug group 2, just go to a regular sharps bin, goes to a regular laundry, and goes to regular garbage. But just a reminder, in the middle of this picture here is the pharmaceutical waste bin. So according to the regulation, if there is any hazardous drugs that needs to be, if it's not empty yet, we have to dispose it here. Dispose it here before putting it onto the proper bin. Cleaning and decontamination. So just like with the presentation in IPAC, when cleaning and decontamination. So this is 2 steps, just like them, 2 steps process, but this one, you have to have the Axel intervention wipe to decontaminate a hazardous drug. So use soap and water first for hand hygiene, as alcohol-based hand rub does not remove any drug residue. Okay, so you have to clean and then you decontaminate. It's important to use Axel wipe because of the hydrogen peroxide component of Axel wipe. Axel wipes, that's the one that would decontaminate the hazardous drugs from the risk of its exposure. Okay, so if there is a spill, what is a spill? So spill is pretty much when there's an open liquid or powder or broken capsule or tablets of any group 1 or group 2 medication. Also, a spill is when there's a blood or bodily fluids from a patient taking group 1 hazardous drug during precautionary period. So when there's a spill, or I should say, when you see a hazardous drug, especially the hazardous drug group 1, you have to know where your spill kit is, okay? Hazardous drug and related waste are transported, received, and stored, prepared, and administered. You need to have a spill kit. And your spill kit does not contain N95. So this is the reason why, one of the reason why fit testing is important to be done annually. So this is what a fit cytotoxic, they call it cytotoxic spill kit, looks like. There is the absorbents, there is the how to cordon the place, gloves, and just some container to get the spills out. Okay, any major spill, in which that major spill means the capacity of the kit, it's more than the capacity of the kit, that's when we call code brown. Or we call code brown if there's no person that's trained to clean the spill, then we have to call code brown. Okay, so when we call code brown, just like any BC emergency code, we dial 7111. We cite the location of the spill, type of substance, quantity spilled, in the time of spill. Switchboard will activate the designated spill response company. So if there's an exposure to this drug, okay, so first is remove contaminated clothing. So remove your clothing, remove your contact lenses. If there's a puncture wound, let it bleed. Wash the area with soap and water. Remember, soap and water. Alcohol-based hand rub will not deactivate the drug. So soap and water is the one that would deactivate it. And if there's blood, flush it with normal saline for 15 minutes if there's skin and eye contact. When things have settled down, call the first aid attendants. Usually it's a security and emergency who does the first aid attendant for the organization. And please do not forget to document PSLS, so it's for your safety, and also to call Workplace Health Call Center, because then they will document that this has happened to you. So it's for your safety. Patient and family education. So while the drug is therapeutic for the patient, but there's also an occupational risk for the staff. So activities such as visiting, talking, hugging do not pose a risk to the family and to the friends of the patient. But if the family is helping with personal care, please encourage the family to wear a PPE because we need to protect the family as well. We have a lot of educational materials available in regards to hazardous drug for patients going to be discharged home. You can get those information and the leaflet for the patient in Connect under patient health education material. Protective reassignment. So this is just a reminder that workers who regularly prepare and handle hazardous drugs have the option to request protective reassignment if they are pregnant, breastfeeding, or intending to conceive. Okay, we don't want to risk people who's trying. So then if there is a need for protective reassignment, please reach out to your manager because this has to be documented between your manager and with occupational health on what would be best for you. This is a high-level presentation of hazardous drugs, pretty much high level. But at the end, we have lots of hazardous drugs. There is a list available. And I want you to know that it's in SHOP. It's in Connect. So that's your first stop, is to find, if you need more information, if you're about to give a hazardous drug and then you saw HD1 and it's color red and you're like, oh, what would I do with this? Please go to Connect and then just type in hazardous drugs. It's in Occupational Health and Safety website, but just type in hazardous drugs and all the information will be here. There's even a list of the hazardous drugs that we have here at Providence, exposure control program, and this is the control matrix and education materials. That's what I'm saying, that it's very useful for people working on the clinical side. Okay? Any questions? All right. So if you don't have any questions, I'm going to be here for another 10 minutes. You can put your questions in Slido, and I'm going to answer the questions as you go. It doesn't necessarily have to be hazardous drugs or interprofessional collaboration. Any questions with regard to your schedule, with regard to orientation, put it in Slido. But if you don't have any questions, I know it's been a long day for all of you. Feel free to log off. Okay, so if you don't have any questions, you can log out. But if you have questions, put it in Slido and I will answer it.